Okay, thank you for joining the fourth virtual resident education lecture series today. Today's topic is neuro-infectious diseases. All participants are muted, and if you are having any technical difficulties, we recommend disconnecting from the webinar and reconnecting. Connect using computer audio or by the dial-in option, and you do not need to use both. If you continue having technical difficulties, send a message through the chat feature and we will try to assist you. For questions, please use the Q&A feature on Zoom and we will answer them throughout. We have Dr. Daniel Weber, Adult Epilepsy Division Director at St. Louis University School of Medicine, joining us as our Q&A moderator today. Dr. Weber started doing a virtual lecture series at the beginning of the pandemic on his own and now has connected with the AAN to continue this resource for residents. I'm also pleased to introduce our speaker for today, Dr. Tracey Cho. Dr. Cho is the Clinical Professor of Neurology, Vice Chair for Education, and Director of Neuroimmunology at the University of Iowa Carver College of Medicine. He focuses clinically on neuro-infectious diseases, autoimmune neurology, and neuro-rheumatology. He has previously served as the chair of the AAN Neuro-ID section and was senior author on a Neuro-ID curriculum manuscript published in Neurology. Dr. Cho, I will turn it over to you.
Thanks so much, Allison. I am very happy to be speaking to you today about my take on the approach to central nervous system infections. As Allison mentioned, I'm happy to take questions during the talk as it will be broken up into different sections. So please type those into the Q&A as we go. I do not have any relevant conflicts of interest. So I'll start with a little teaser, and I don't think it's going to be too hard for most people. Look at the images and see if you can match the images with the neuroinfectious disease syndrome. Give you just a moment to digest these. So hopefully you recognized each of these. This matching exercise is to get you thinking about syndromes and the fact that different infections are more likely to cause one syndrome than another. And so localizing that syndrome can help you identify which microbes are most likely the culprit. So I'm going to outline my approach, and it's fairly typical for how we approach all things in neurology with a couple of nuances. So you start with identifying the syndrome based on history and exam. That's localizing. You define the time course. So something that's been going on for several months has a different set of possibilities than something that happened over a day. What's unique in some ways about neuroinfectious disease is that we focus on the immune system, and that affects your differential. So someone who's got advanced HIV or who has lived in an area of the world that has endemic infections that are different, those are factors to also consider. Then you confirm your syndrome with additional testing, whether that's imaging or EMG or sometimes EEG. And then you take a sample of the relevant tissue when you can, whether that's blood or CSF or sometimes the brain or spinal cord parenchyma itself. So let's look at the different CNS infectious syndromes. I have them listed here, and we'll go through some of the clinical symptoms that you might expect with each of these. So meningitis. Meningitis obviously is inflammation of the meninges. That's the lining of the brain. When it's due to an infection, fever is very common. Classically, patients also have neck stiffness. And even though it's on the outside of the brain, it often causes brain dysfunction. And so patients have mental status changes, headaches, and sometimes seizures if it irritates the cortex enough. It can be really tricky sometimes to distinguish between meningitis and encephalitis, and you can also have both at the same time. Encephalitis, like meningitis, when it's due to infection, often includes fever and headache, mental status changes. Seizures are more common with encephalitis than they are with meningitis, And you're also more likely to have focal findings with encephalitis than you would with meningitis. Typically, the behavioral changes that you see are more prominent and happen earlier in the course when the process is directly affecting the brain parenchyma versus the meninges and then spilling over into the parenchyma. Myelopathy is obviously much different, and classically you have bilateral extremity weakness and numbness. Depending on where in the spinal cord, it might involve all four limbs or just the lower limbs. Bowel and bladder dysfunction is quite common. And then focal mass lesions in the brain, such as those due to an abscess, typically will present with a headache. They may or may not have a fever. They typically are a little bit more subacute than the meningitis and encephalitis that are due to infections. Anything in the brain that takes up space can also give you signs of increased intracranial pressure, so nausea, vomiting are also quite common. So now that we've talked about identifying the syndrome and acknowledged that sometimes it's tricky to differentiate between encephalitis and meningitis, let's look at time course. So acute infections of the central nervous system are dominated by bacteria and viruses, both for meningitis and for viruses for encephalitis. So these patients typically present within hours to a few days. Subacute syndromes are more typical for atypical bacteria, spirochetes, mycobacteria, fungal organisms. HIV and autoimmune causes of encephalitis often present over a longer time course than your typical viral encephalitis. Progressive multilocal encephalopathy, and then the mass lesions due to either bacterial abscess or things like toxoplasmosis, and on your differential with that would be neoplasm, typically present over weeks rather than a couple of days. Chronic infections are less common, but all of the same organisms that can cause a subacute meningitis can also cause a chronic meningitis. Sometimes these infections brew for a while before they start causing more significant symptoms. But even these, it's still rare to have more than a few weeks of symptoms before things get so bad that patients have to seek attention. There are a couple of chronic encephalitides due to infections. The big one is HIV, and then measles can sometimes later manifest with subacute sclerosing panencephalitis. And then a rare category is recurrent CNS infection. The main syndrome that we think of here is recurrent viral meningitis, most typically due to HSV2, but some of your autoimmune diseases can also recur and can be confused with infections. So moving on, host factors and exposures, or the environmental factors that play into infectious possibilities. Immunocompromise is a big and obvious one. HIV is a common cause of immunocompromise, but more and more we are using immunotherapy for our patients or taking care of patients who are on immunotherapy for other diseases. And those can expand the differential for the possibilities. Geography and season also play a role. Lyme disease, which can cause an aseptic meningitis, is very unusual in the heart of winter or in places that don't have a lot of deer ticks infected with Borrelia. Patients who've lived in parts of the world endemic for tuberculosis are more likely to have that cause meningitis than someone who's never lived in that region. So when you're taking a history, these are things to keep in mind to help narrow or broaden your differential. A third factor for hosts is whether they've been vaccinated or are on prophylaxis for certain infections. Most of the developed world has good access and fairly robust vaccination programs, although there are still, even in developed countries, sometimes parents refuse vaccines. So that opens the door to some other possibilities than you would expect normally. Toxo is prophylaxed against in HIV patients who have advanced disease, and whether they're on that or not definitely impacts their risk of having toxo in the brain. So with that background for general approach, I'm going to go through some cases to illustrate how to use these principles to try to sort out what's going on.
Can I pause you for one quick question?
Sure, Dr. Weber.
Further hitting on that differentiation between meningitis and encephalitis or meningoencephalitis, is there like an amount of mental status confusion with meningitis that makes you presume that the encephalon is also involved, or seizures as the case may be? Like, where do you draw that line?
So my approach is to assume anyone with headache and altered mental status could have HSV encephalitis or bacterial meningitis, because those are the two things that could kill you within a day if not recognized and treated. And honestly, it's really hard to distinguish those, particularly if the patient's altered enough that they can't tell you about the time course or you don't have good history. So the bottom line is there's no 100% reliable way on history and exam to distinguish those. Even on MRI and CSF testing, the lines blur frequently. So from a practical standpoint, I often start off assuming it's either of them. And then with additional testing, I hone in, and particularly with imaging, that if it's focal and clearly predominantly in the brain, I look for more of the encephalitides causes, whereas if there's no brain involvement on imaging, even if they have altered mental status and seizures, I focus more on the causes of meningitis. All right, let's start with a case. A woman in her 40s with no past medical history developed right ear pain and drainage, followed by fevers, chills, and headache. Later the same night, she developed vomiting and confusion. She presented to the emergency department. On exam, she was febrile to 103 Fahrenheit. She was confused and agitated with a stiff neck, but was otherwise awake and neurologically normal. She did not have any focal findings on exam, on her neuro exam. Additionally, there was no rash, but she did have some discharge from the right ear. So I will pose a question to the audience. What syndrome is most likely based on the presenting clinical symptoms and signs provided? Acute meningitis, subacute to chronic meningitis, acute encephalitis, encephalopathy, or a space occupying lesion. I don't have the talk set up to account for everyone's answers, but thank you to anyone who can put them in.
You're getting a handful of A's in the chat box.
Yeah, I'll go with that. You are correct. She presented the same day her symptoms started, so definitely acute. She does not have focal neurologic signs or significant encephalopathy, and she's got meningismus. So acute meningitis is the most concerning possibility. She had blood cultures drawn immediately and was started on ceftriaxone and vancomycin empirically, as well as dexamethasone. She underwent a non-contrast head CT, which did not show any mass effect, but did show some indications of mastoidosis on the right, where there was not the air that you typically see. CSF was obtained after CT because the CT was obtained pretty rapidly, and that showed 735 white blood cells with 94% neutrophils, glucose of 18 with a normal cutoff of 40. Protein was 550, and it was grossly cloudy in appearance. Another question for the audience. What is the most likely organism for this patient? H. influenza, tuberculosis, listeria, Neisseria meningitidis, or strep pneumonia? Well, you guys are smoking it. I see a lot of E's. And the E's keep coming. That is correct. So she had gram-positive diplococci in pairs and chains. It actually grew from both the CSF and the blood, and was pan-sensitive. She was narrowed to ceftriaxone, got 4 days total of dexamethasone, and actually quickly improved. So strep is indeed the most common cause of bacterial meningitis, and it is also the most severe cause. It can occur in patients of all ages and all types of immune hosts. So you definitely don't have to be immunocompromised to get this disease. Neisseria is more common in older children and young adults, particularly in people living in close quarters, which is why it's now mandatory in many countries that children entering middle school or junior high are vaccinated against this. And a lot of these patients have rash due to thrombocytopenia, which is illustrated here in the photo. And then another cause to keep in mind is listeria, which is more common in young children and older adults or those who are immunocompromised. Getting back, I see a question about this patient received antibiotics but not acyclovir. I think it would have been reasonable to hit her with acyclovir up front as well. I believe the emergency physicians in this case, which is a real case and I didn't alter it, probably because she had the discharge from the ear and no altered mental status, they felt confident that it was likely bacterial because of that combination of her presentation and the lack of altered mental status. But it would not be wrong to start acyclovir. You're never wrong to give a dose of acyclovir until the dust settles. So CSF culture is the gold standard for bacterial meningitis. It gives you susceptibility in addition to the specific bacteria. There is a typical profile that I'm sure you all know. Low glucose is common, elevated protein, and significant pleocytosis, often more than 1,000. This is not commonly used, but an elevated lactate can help distinguish bacterial from viral meningitis, but we don't rely on that typically. This profile is quite variable, and it depends on where you catch them in the illness, whether they've had any antibiotics or not. Unfortunately, there's no cutoffs on the standard CSF profile that absolutely excludes bacterial meningitis or that it's viral versus bacterial. Some caveats when looking at CSF. As I mentioned, prior antibiotics can affect the profile, although the white blood cell count tends to remain elevated even with prior treatment if there's a delay in getting the CSF. Your protein and glucose might normalize some, but the white blood cell count tends to remain elevated for several days, if not longer. There are a handful of viruses that can actually cause low glucose, although that's rare. And then likewise, there are some viruses that have a neutrophil predominance, particularly early on, especially enterovirus and HSV. They later shift to a lymphocytic profile. So gram stain is fast and has a good sensitivity and specificity. But again, is obviously impacted by whether the patient receives antibiotics before they get the spinal tap or not. Again, culture is the gold standard. It has a good sensitivity, but not perfect. And the main issue is that it takes a couple of days to get that result back. Most large centers now incorporate a film array called BioFire. In our institution, it's ordered as something called a meningitis encephalitis panel. It is basically a one-stop shop for 14 microbial pathogens that tend to affect the central nervous system. It's not specific for meningitis. It covers things like HSV, which more typically cause encephalitis. But the benefit of this is that you don't have to wait to see what the CSF profile is, and you don't have to send one test at a time, depending on what comes in. And it's very rapid, so it gets back within a couple of hours. So most, like I said, most larger centers incorporate this in their infectious neurologic testing. Treatments are based on those most common organisms I mentioned earlier. So ceftriaxone covers most of them. Vanco is added for penicillin-resistant strep pneumoniae. And then ampicillin is there for the listeria. Dexamethasone is recommended in patients who have strep pneumoniae. Often you don't know what it is up front, so it's appropriate to start it. If you find out that it's something else, you can stop it. It has shown benefit mainly for strep because strep is the most severe. It's unlikely to do harm in other cases, but if you know it's due to a different bacteria, then the recommendation is to stop it.
There are a couple of questions on the dexamethasone that have come up. It sounds like you've answered the first one. Your practice for using steroids sounds to be give that first dose while you're trying to figure out what's going on. And if it's not strep pneumoniae, then go ahead and stop it.
That's correct.
And then the other one is, what's the timing relationship? When do you give the dexamethasone?
Right, so ideally, the original studies, the dexamethasone was given before or at the same time as the antibiotics. There's been some subsequent data and smaller studies showing benefit even if it's given shortly after antibiotics. So if for whatever reason, logistics or just it wasn't recognized, and you find out after the antibiotics have already been started, it is still reasonable. There's not an evidence-based hard cutoff, but generally within a few hours after antibiotics is still fine. 2 days later is not the time to give it. It's not going to help at that point.
So if someone else was managing the case initially and hadn't given the steroids and you came in later, you would not give it subsequently, even if you found out if it was strep pneumonia.
Correct. Not if it's a day later.
Sure. And the diagnostic test that you had talked about, the
film array.
Yeah.
Yes, it is mostly PCR based.
Okay.
There are some antigen tests in it, but it's mostly PCR. And it's all contained in this one little box that's proprietary and sold, and all the reagents are there. So it's anyone who has electricity and a tech basically can do that.
And would you recommend Dex for any viral encephalitides or I assume that's Haemophilus?
H influenza B, I think is what's being referred to there. So thankfully that disease is less common now. The recommendations in children are also to use dexamethasone for prevention of hearing loss in children with H influenza B. Penicillin and cephalosporin allergies. So when I get to that level, I ask, usually ID's already on board. So I'm not going to do the second and third tier recommendations. There are other options. So obviously vancomycin will cover a lot of that. Sometimes vancomycin is a very big molecule, and there have been some cases where people got dexamethasone and they had penicillin-resistant strep, and the dexamethasone helps to close your blood-brain barrier because it's reducing that inflammation, and that can make it harder for vancomycin to get good CNS penetration. So sometimes we add rifampin if patients aren't getting better in that scenario. There are other options like chloramphenicol, but I don't, I'm never going to be the one who gives those sort of second and third tier level recommendations. All right. Prognosis wise, I think of bacterial meningitis as a bimodal disease. You're either really bad off and potentially die, or you come out relatively unscathed. If it's not treated, you die. That's clear. Even with proper treatment, there's very high mortality, but only about 10% of survivors have neurologic impairment. And that's in contrast to, for instance, HSV encephalitis. Obviously, being older puts you more at risk for, and then strep is worse than others. And then obviously a delay in antibiotics also gives you a worse prognosis. So I am done with bacterial meningitis. See another question. Time of initiation of antibiotics is right after CSF collection. Not sure I understand the nature of that question. Sounds like if it is fine to start the antibiotics while you're waiting on the CSFs come back normal, you can stop it. It is always better to start antibiotics in someone who doesn't need it than it is to delay antibiotics in someone who does need it. It's like you need to take out some normal appendices not to miss appendicitis.
And you wouldn't delay the antibiotics even for the lumbar puncture itself, correct?
Correct. The recommendations are not to do that. In practice, in developed countries, you can get a CT in like 10 minutes.
Yeah.
There are, in larger centers. In smaller centers, even in developed countries, that may not be possible. And clearly, you should not delay. There are, it's beyond the scope of this talk, there are criteria that people have put out there for when you must do a CT first to avoid the risk of herniation from a mass lesion inside the brain. So if someone has a focal lesion or has a advanced HIV or other causes of immunosuppression, they're more likely to have mass lesions in the brain that could be masked and need to have imaging first. But that's very rare that it's necessary before you do the LP.
But even if, say, there wasn't anyone available to do the LP at that moment, you had antibiotics available, you put in the antibiotics and do the LP when you can.
So you draw blood cultures because you get your answer in a large majority just from the blood. A lot of these people are bacteremic at the time that they have meningitis as well. All right, I will move on to the next case. A woman in her 60s developed headache for 2 days, then fever and slurred speech. She was initially treated for a urinary tract infection, but then developed aphasia and ongoing fever. On exam, she had a temperature of 39.4 and a mixed global aphasia, but otherwise she had no weakness and numbness or hyperreflexia or other focal neurologic signs. So what syndrome is most likely here? So I'm seeing a lot of C's, an E and a D. This one's not as straightforward. So she presented within 2 days, so I would call that acute. She has behavioral changes, so C, D, or E could certainly cause that. The answer I was looking for was acute encephalitis, and I'll go through why that's the most likely one here, although you certainly could have a systemic infection with fever causing encephalopathy. I try to teach students and residents to really hone in on whether a patient is encephalopathic versus aphasic, because aphasia is a focal sign that is not typical for encephalopathy in isolation. That can be tough when someone's aphasic to determine whether they're also inattentive, but there is a difference. So that's why I think acute encephalitis is the most concerning possibility here. So MRI was obtained, and I will scroll through this. Flare is on the left and T1 post-contrast on the right. And you can see that there is T2 hyperintensity in the left temporal lobe and insula. with minimal enhancement. On DWI, there's also a hint of restricted diffusion in the same area, although it's obscured some by the skull base artifact. What is the most likely possible etiology to consider and treat initially? All right, everyone is on the B. Herpes simplex type 1 is a neurologic emergency. You should be treating for this way more than you actually diagnose it. So she was started on acyclovir immediately. However, she continued to have progressive speech and memory problems and seizures requiring 2 anti-epileptic medications. For a couple of non-medical reasons, LP was unfortunately delayed and was obtained 2 days later. She was negative for HIV and syphilis. Her CSF showed 207 white blood cells with a lymphocyte predominance. She had a few red blood cells. Protein was 160, so moderately elevated. Glucose was normal. HSV PCR was negative.
Is there a point of delay where you would no longer pursue an LP in either this case or bacterial meningitic case?
That is a good question. It's kind of a style thing. I would say for meningitis, you're committing to several weeks of treatment. I would say if you're on the fence about whether it's bacterial meningitis or not, and you were just doing it just in case, I would still consider doing it. The white blood cell count could still be up. If it were completely normal, it might impact how long you treated, but so it depends on how by the book you want to be and whether the patient's tolerating the antibiotics or not. For HSV, I essentially always get an LP win unless there's some absolute contraindication. If someone is on, so in bacterial meningitis, when you're on antibiotics, the CSF becomes sterile, so you can't grow cultures within hours. For HSV on acyclovir, it takes several days often before you lose the PCR detection of the virus. So if someone's been on acyclovir for a week, then it might not be worthwhile, but a couple of days is definitely worthwhile. If you do it really early, it might be negative because you do it too early. And in those cases, I usually repeat it within 2 days while on acyclovir the whole time. So HSV typically presents with fever and personality changes. It's fairly almost uniform, almost. There's no 100% in anything. About 2/3 of patients will have seizures. They're not always clinical, but because it affects the medial temporal lobe, it's very eleptogenic. Focal findings are also common, not just cognitive, but motor symptoms as well. And it tends to progress over a week. So it's a little bit longer than bacterial meningitis, but it's not something that simmers for weeks and weeks and then comes on. With the exception of immunocompromised patients, they might have a more indolent presentation. MRI is almost always abnormal. It's obviously more sensitive than CT. So in patients who have a proven HSV PCR positivity, more than 90% of them are going to have an abnormal MRI in a way that is typical for HSV. It tends to affect the temporal and orbitofrontal regions, so your limbic system with T2 signal, T2 hyperintensity. Sometimes the diffusion can pick it up earlier than the flare. But again, like the HSV PCR, the MRI might be normal very early on in the course. Chronically, often the encephalomalacia is much more than what you see in the acute injury. So a lot of times, even when you hit them with acyclovir, It's like slamming on the brakes on a truck going downhill. It tends to continue skidding for a while before it stops. So PCR is the gold standard. These patients used to have biopsies as a gold standard, but PCR has replaced that. CSF is typical for viruses with lymphocytic phagocytosis, normal glucose, and a moderately elevated protein. Again, it can be normal very early. So you have to use your clinical judgment about, how whether they're febrile, how typical the syndrome is, and really on a case-by-case basis, whether you need to continue treating or repeat the LP. So PCR is very good. It has about a 94% sensitivity and 100% specificity. We already talked about it being negative very early on, or if you've been on prolonged acyclovir. So treatment is acyclovir 10 mg per kg every 8 hours for 21 days. There are different studies showing 14 to 21. This is such a bad disease. I almost always do 21. The one side effect to look out for is renal failure from crystallization of the drug metabolites in the urine. So if you hydrate patients, you can help prevent this. If a patient presented the way this one did, with a limbic syndrome and a fever coming on over days, it's nice to have the PCR positivity, but I'm not going to do anything that I wouldn't do for an HSV positive patient here. So continue the acyclovir for the full course. It also covers VZV, although VZV does not tend to cause limbic encephalitis as prominently as HSV does. Like we talked about with bacterial meningitis and covering for HSV, the flip is also sometimes necessary if patients come in with fever and altered mental status over a couple of days until you get an MRI that looks like this, or CSF with your HSV PCR.
There are a couple questions on the PCR that have come up,
Sure.
And they all essentially go around points that you touched on. So even in HSV PCR cases, you would treat. Are there specific things that push you over that edge? Obviously, the clinical syndrome being typical makes you more apt to treat. Are there specific things about the clinical syndrome that you for sure are going to treat this patient versus another?
So there's no black and white rule of thumb. If someone has fever and altered mental status, I'm going to start them until I get more data. If the MRI is normal and the CSF is normal, despite them having significant symptoms, then I start thinking about other causes, autoimmune in particular. If the MRI is abnormal or the CSF shows a pleocytosis, even if the PCR is negative, I'm typically going to treat those patients, especially if they have a limbic syndrome. Mm-hmm. If it's more nonspecific, then it's more case by case, but there's not a hard, fast rule.
And what's your thought on specific timeline for how early is very early for the PCR to be negative, and how long for acyclovir treatment before it'll be negative again? Just a rough, not a hard cutoff for that either, but.
Sure. So if a patient's having enough symptoms and bring them in to get an LP to begin with, and they get the LP the day that, the minute they walk into the ER, I would repeat it within 24 to 48 hours. So that's early as someone who had symptoms for a day comes in and gets an LP immediately. If they've been on acyclovir, there's some small studies showing the positivity of the PCR drops off somewhere between 5 and 7 days. As this case illustrates, even after a couple days, sometimes it's negative, assuming I'm not wrong about this patient's diagnosis. So hopefully that answered the question.
And do you routinely get EEGs in these patients?
I do not. I use the same criteria I use for all patients, and that is if they've had a seizure and they don't return to normal, I get one. If they have ongoing altered mental status when I think they should be improving, I will get one. So that last one is, when should they start improving? That's a judgment call. So it's never, wrong to get an EEG. A lot of these patients will have seizures and can certainly have non-convulsive seizures. So I also have a very low threshold to start antiepileptics in these patients, even without an EEG, if I think there's any suggestion of, episodic or fluctuating mental status or any convulsions.
And if you do get an EEG and it shows PLEDs or LPDs, does that help you in your diagnostic thought process?
I'm not sure if that's on the boards anymore now that we have MRI and PCR. That in old textbooks, and by old I mean like 10 or 15 years ago, the EEG, or probably older than that, the EEG was one of the main additional tests that help get you this diagnosis short of a biopsy. So obviously those are not specific to HSV. If a patient comes in with a lateralized limbic syndrome, it's not surprising to see PLEDs in that distribution. So it's still a style thing whether to treat PLEDs, and we could spend several hours and not get anywhere on that question. But if I have a low threshold, often PLEDs in patients with HSV means they're having seizures too, and you haven't caught them. So it's not specific for HSV. It would not preclude me from checking the PCR. And then it's a judgment call about whether to use antiepileptics.
And is there any other HSV related CSF tests that you would send off if the PCR were negative and you had a high suspicion?
So that's a good question. So HSV PCR is on that 14 microfilm array panel, the BioFire panel or meningitis encephalitis panel. It has been compared to the individual HSV PCR assay, and it's fairly equivalent. If your panel is negative and you're super suspicious, you can ask them to additionally run a separate HSV PCR. There are no other tests for HSV. The antibody tests are not helpful because it's so common to have the antibodies, and that it doesn't really help you. Hopefully that answered the question.
Yep. And could you please go into a little more detail on what you mean by limbic syndrome?
So limbic syndrome, yeah. So limbic system, inferior frontal lobe, medial temporal lobe, cingulate. Patients present with memory problems, behavioral changes, and seizures. So it's not specific to HSV. It's also common with, for instance, LGI1 limbic encephalitis. And so it's shorthand for the areas that you see abnormal in the MRI.
So one of the great things about these talks is the audience is always very engaged, but I'll ask you one more question, then let you get to some of your actual lecture, because I think we're going to run out of time again.
No worries.
If there's no improvement with acyclovir, would you use another antiviral? And if so, when?
That is, so there's no good evidence that using ganciclovir or foscarnet are helpful unless someone's been on chronic acyclovir, like a transplant patient or something, where they might have developed resistance virus. Again, that's a point where I would get infectious disease involved and maybe try to sequence the virus from the PCR if you can. All right. So bad disease untreated, about 70% fatality, but even if you survive, there's a very high rate of residual neurologic morbidity. Okay, I will try to get through one more case. A man in his 30s developed 3 days of episodic left-sided tingling lasting minutes. He later developed left hand weakness. He had no fevers, night sweats, weight loss, IV drug use, or alcohol abuse. He was afebrile on exam with some mild left motor neglect and slightly increased reflexes on the left. What syndrome is most likely based on this clinical presentation? All right, in the interest of time, we have 1, 2, 3, 4. Okay, now we've got a bunch of votes for E. Great. Here's the flare on the left and the T1 post contrast on the right. As we get towards the top, you see a T2 hyperintense ring around a T2 isointense core with some surrounding rim enhancement right in the hand area of the right motor cortex, which is kind of sweet anatomy. And here's the same lesion on coronal and sagittal. So this is a poorly written question. I'm just going to get that out there. This wouldn't make the cut for boards, but for the purposes of teaching, and there may be more than one good answer here, but what's the most important one? And this is a good example of why it's a bad question. So we have several votes for B, 1 for C, 1 for E, 1 for A. They're all good things. Actually, it makes me happy that no one has put D, because indeed, D is not helpful. So CSF, it not only might not be helpful, it might be contraindicated. Usually, so this guy looks like he has an abscess, so not a mystery. When they're walled off like that, you're not going to get a lot of added information from CSF because it's not spilling into the CSF. And if there's a significant amount of mass effect, you run the risk of aggravating that with removing CSF from below. So diffusion-weighted imaging can be very helpful for differentiating tumor from abscess. So that is a great answer. An echocardiogram would be very helpful, particularly if the patient had multifocal abscesses from a hematogenic source, because endocarditis is a common cause for that. Likewise, blood cultures in that setting would often be positive. But ultimately, you treat and diagnose this entity by sticking a needle in it or getting our friends to do it. So pyogenic abscess. So abscess due to pyogenic bacteria. The symptoms you get are just mainly from the mass effect within causing increased ICP and local deficits depending on where the lesion is. So headache is very common, but fever, only about half of people have fever, like our patient. He did not. Nausea, vomiting, and lethargy get more severe as the disease progresses. And then again, focal deficits, depending on where it is. These patients have 8 days of symptoms on average. So it's kind of at that cutoff between acute and subacute. Some imaging features. It's typically at the gray-white junction because that's where they lodge in the little arterioles. The cavity is often iso-intense on T2, and then the rim is often hypointense, and then there's the hyperintense edema around it. As mentioned, diffusion-weighted imaging, because pus restricts water diffusion, it actually can look as bright as acute strokes do, whereas glioma and lymphoma are not going to have as much diffusion restriction. And then sometimes tumor factive demyelination can fool you. If you see incomplete rim enhancement, that's helpful. If you don't, that doesn't rule out demyelination, but abscesses typically have complete rim enhancement. So blood tests, ESR is going to be elevated in a majority of patients, but obviously not specific. About a third of patients will have positive blood cultures if they have multifocal lesions. HIV must be checked in all patients because that changes the options, including toxo being a big one. And as I mentioned, CSF is not going to add a lot. So this is one of the few scenarios where I say, don't bother sticking the needle in the back. Aspiration using imaging guidance is now the standard definitive diagnostic technique, but it also can relieve mass effect by aspirating out the pus. It can be relatively non-invasive. It depends on where the lesion is. It also gives you specifics about what's in there and what antibiotics you need to have them on. Craniotomy is not done that often, but in some cases where it's multiloculated or you have like a trapped temporal horn, or patients are not responding to antibiotics, sometimes you have to get more invasive. So impaired coverage includes Vanco, a third or fourth generation cephalosporin, metronidazole, and meropenem. So you're covering most abscesses are actually multimicrobial, including both aerobic and anaerobes in the same lesion. It's like a cesspool, and everyone comes to the party. Once someone starts, sets up the keg, everyone and their brother comes and crashes the party. Prognosis-wise, mortality is 100% untreated, but with treatment, it gets down to 10%. So not zero, but obviously way better. Getting back to our patient, he had restricted diffusion in the lesion. He had basically normal labs and a normal echo. HIV was negative. He was biopsied and it grew pan-sensitive strep anginosus or strep milleri. And so despite what I said about it mostly being multimicrobial, because his was small and he responded very well, he was treated with ceftriaxone. I believe he was initially on broad spectrum empiric coverage, and then after the biopsy, it was narrowed. On follow-up MRI, it almost went completely away. There's just a little bit of gliosis here. All right, I'll pause there. Did I miss any questions?
Yeah, there were a couple.
Dr.
Could you
Weber?
go in more specifics on how you might differentiate tumefactive MS or tumefactive demyelination from an abscess, if there are any tricks that you use?
The imaging tricks I just went over can be helpful. Bottom line is you often have to stick a needle in it. And that's true for tumor versus demyelination versus abscess. We can hem and haw over imaging features or the ESR. If even the CSF bands and things like that are not reliable enough. So if someone has other features of demyelination, that can be helpful. So if you know they have MS,
Sure.
then that's, hit them with steroids, and if they're not febrile, you can treat, presumptively. But a lot of times for a new presentation with no known demyelination, a biopsy is necessary to differentiate these things.
And you often start the treatment with all 4 of those antibiotics together and then taper down once you have the actual answer. When do you expect LP pressures to normalize in meningitis, and when do you expect MRI findings to normalize after treatment of abscess?
So for the first question, I don't know the data on that offhand. In general, the CSF inflammation improves with antibiotic treatment. over days to weeks. It depends on the nature of the meningitis. So most bacterial meningitis definitely raise the ICP, but generally with treatment, if you survive, most of those patients, it comes down within days to weeks. Cryptococcal meningitis, on the other hand, even with effective treatment, often deposits all kinds of protein in your arachnoid villi. And those patients, sometimes even when they're not having any more replication of the fungi, have rip-roaring high ICPs requiring daily LPs or even sometimes shunting. So it varies. I don't repeat imaging on patients with an abscess who are getting better clinically after treatment and with definitive stereotactic aspiration for at least several weeks. So it's not unusual to see ongoing enhancement, and you can hem and haw over whether it's working or not. Even occasionally, my ID colleagues will get imaging at the end of antibiotics, and there's still some enhancement, but the patient is back at work doing great. And so sometimes some patients have some residual enhancement. It doesn't mean there's ongoing active infection.
So you wouldn't necessarily change the treatment course based on the imaging follow-up?
If they're doing clinically well and the imaging does not look worse, I typically do not change the treatment based on persistent enhancement. Sometimes I'll get another scan, 3 to 6 months later. But unless there's some change for the worse on the imaging or any clinical lack of expected clinical improvement, I don't do anything with a little bit of residual enhancement.
Are there any imaging findings that would make you lean towards or away from specific pathogens like tuberculosis or toxoplasmosis?
Toxoplasmosis is more often going to be multifocal than solitary, but there are definitely solitary lesions. All of those same features, the gray-white junction. Toxo also likes the basal ganglia. I guess that's a little bit different, but not definitive. Tuberculosis, and I don't know the underlying pathophysiology, but it tends to cause much more edema than other lesions around the tuberculoma.
Mm-hmm.
But ultimately, the short answer is no. There's no way short of finding the bug either in the brain or in other fluids to differentiate them. Obviously, if someone has advanced HIV, there's statistics. You just play the game and you treat them for a toxo, and if they get better, you can avoid biopsying them. But outside that scenario, it's really hard to do anything other than sample the lesion.
Fair enough. And I think you had mentioned earlier that you tend to not use CSF antibodies for herpes diagnosis, specifically questions about the IgM antibody. Have you ever used that?
No.
Okay.
The IgM can be helpful for West Nile.
Mm-hmm.
Because that is not a ubiquitous virus. It comes in epidemics. And IgM is a very large molecule. So you're not going to get systemic West Nile virus IgM spilling into your CSF unless the West Nile is in there.
Fair enough.
So that's the scenario where I use an IgM.
Have you ever used ribavirin for lacrosse?
I have not, and my understanding of the literature is that none of the arboviruses have an effective antiviral treatment. So it's supportive treatment for all of them.
You haven't just been throwing some wacky things at things, trying to get some.
Well, ribavirin, I mean, they're bad illnesses, and they definitely have been tried in series and case reports, but I don't see a lot of lacrosse anyway. But for other arboviruses, unfortunately, we don't have specific antivirals that are effective. Any
particular thing to differentiate between ADEM and multi-brain probably the same sort of ideas that we're talking about here.
Yeah, so I go looking in the spinal cord to see if there's any myelitis. You want to do careful history and exam regarding things like optic neuritis. So if you see signs of demyelination elsewhere in the CNS, that's a big tip-off. Typically, ADEM happens 2 weeks after someone is febrile, whereas these diseases, they're febrile at the time they have the neurologic symptoms. But otherwise, it can be really hard to differentiate.
We got through all the questions. I don't know if this has happened before. Maybe not all the talk, but all the questions anyway.
We got through enough of the talk.
Good. Great talk. Thank you very much.
Thank you, everyone.
Yes, thank you everyone for joining our 4th AAN Virtual Resident Education Lecture Series. So these are recorded and will be available through AAN.com or AAN YouTube as soon as we can post it. The next series date is still to be determined, but keep a lookout for any information on AAN's social media channels. Thank you for joining.